To our attendees from out of town that's going to join us virtually, you are most welcome. And then we also have attendees from other healthcare professions. You are just as welcome. I want to take the opportunity to thank PCI for the sponsorship. Without sponsorship, we can't have these events. Mrs. Moorbrok, thank you for organizing this event. And Meintjes, who is doing the live streaming. Thank you very much. Well, I want to introduce our speaker to you, Ms. Gloria. We've got international taste to our speaker. Gloria was born in Bucharest, Romania. She studied at the University of Medicine and Pharmacy. I don't know if I'm going to pronounce it correct. Carol Davila.
Perfect.
Thank you. In Bucharest, where she graduated cum laude. She then went on to do a specialist degree in clinical, hospital and managed care, where she qualified as a clinical pharmacist. After her studies, she became a responsible pharmacist in a retail pharmacy in Bucharest. She worked as a regulatory affairs specialist with Johnson & Johnson in Romania for several years. And then she did a very good thing. She moved to South Africa in 2013. Gloia's academic journey started at the Nelson Mandela University in 2016, where she teaches pharmacology in clinical modules of the B-Pharm and B-Dietetics degrees. Fascinated by pharmacogenetics, Gloria is on a mission to help individuals to understand how genetics can influence treatment outcomes. She is a GeneWay DNA testing and wellness practitioner. Gloria, the floor is yours. Thank you.
Thank you very much. Good evening, everybody. I had so many smart things to tell you at the beginning, and I forgot them all. It's a pleasure being here tonight, and thank you, PSSA, for organizing this event and for having me here. Just to give you a bit of background, how did we end up with this topic, diet and medicines? A while back, I was asked at university to teach pharmacology to dietetics. And when I started to prepare for them, I thought, this is quite interesting, actually. But how come dietitians need to know things about drugs, but we as pharmacists don't know enough about diet and how we need to counsel our patients when we dispense the medicines? Because as my colleague always says, we are the custodians of the medicines. And we are the ones that need to counsel the patients when we dispense, not only in take it twice per day or 3 times per day, but how do you take it? What do we need to avoid? What do we need to be mindful of? The side effects, the interactions, and not only interactions with other drugs. There are interactions with foods as well, as you will see. Okay, so that is the context, and that's what brought me here. And because PE is a small place, my colleague joined me in the program, and then she spoke with Alice, and Alice thought that's a good topic for a CPD evening. So with that in mind, without further ado, let's start. Okay, so we'll cover a bit of pharmacokinetics and pharmacodynamics. I know some of you have shivers from varsity still when it comes to pharmacokinetics. Believe me, when I moved here and trying to teach pharmacy in English, it was a different language altogether. So, okay, and because I have an accent, I forgot to mention this, apparently everybody tells me I have an accent, I will try to slow down the pace so that you guys can understand me. Okay, so we'll look at food-drug interactions from pharmacokinetic and pharmacodynamic perspective. We'll touch slightly on supplements and drug interactions because I'm sure some of you know about supplements and how they interact with drugs. And then a reminder that patients do need to change their diet because of the side effects of the drugs. It's not something that we always remember to reinforce to our patients, and we'll finish with a short conclusion. Okay, so just to put things a bit into context, when we talk about drug-drug interactions, we have plenty of studies, research, meta-analysis, all over the place. You can find it very quickly. But when it comes to food and drug interactions, we don't have so much info. And that is mainly because in foods we have lots of compounds, and it's very difficult to pinpoint which compound is actually at fault for an interaction. We don't have a lot of data, and when a research is conducted, it's normally conducted on a small pool of patients. So we don't talk about thousands of patients, we talk about hundreds of patients, or sometimes 50 patients only in a study. The other thing that is quite difficult, and the penny for me only dropped reading to prepare for dietetics for their lecture, and I know we have a colleague here that is very passionate about wine, and probably she will be able to, because I was reading and I was thinking, but this makes sense, because when you make wine, the same wine by different year tastes differently. Why is that? Because the grape is different based on the soil, based on how much water you had that year. If you had a year with drought, then it will not be as sweet. You didn't have enough sun. So all of that applies to all the foods, actually. The content of the compounds inside change based on where you grow the fruit or the vegetable, what did you use to make the soil richer, to grow the food. So all of that plays a role. Okay, so just to warm you up, I want to run a quick quiz. Yeah? I will give you a bit of time to read the question, and please don't nitpick on the fact that gin is not a food. For some of us on a Friday evening, it can be, just saying. So I'll give you a few seconds to think about it. Somebody did their homework. Okay, so the correct answer is Marmite. Yeah? Marmite. Why is Marmite the correct answer? As I always refer to myself as a nerd, but apparently there are others that also do a bit of research. It's because of the cheese reaction, yeah? So many years ago, I think it was 1950-something, when selegiline was prescribed as an antidepressant. And at that point, a patient started to feel better on selegiline and threw a big party. And at this party, she had guests and she served lots of mature cheese and red wine. And that is the first time this reaction was noticed, that she ended up in hospital with a hypertensive crisis. And they picked up that the reason was that selegiline is a monoamine oxidase inhibitor, same as moclobemide. Therefore, it will increase the level of catecholamines, amongst which noradrenaline and adrenaline. The outcome of that is that when you eat foods rich in tyramine, you end up with, while you are on moclobemide, you end up stopping the breakdown of tyramine in foods, meaning that tyramine then will be able to release more catecholamines. So your levels of noradrenaline will push up, therefore you will end up with an increase of blood pressure. Okay, so Marmite is not the only food that we need to be mindful when it comes to treatment with monoamine oxidase inhibitors. We have quite an extended list of foods. You can pick and choose, but the main criteria is your fermented foods are the main culprit when it comes to tyramine, and apparently tap beer is worse than your beer in a bottle in terms of content of tyramine. When it comes to wine, red wine, it's the one that we need to have in mind. So this is just to warm you up, and now we'll start to look more at pharmacokinetics and pharmacodynamics of food-drug interactions. Okay, so in terms of pharmacokinetics, I know you don't want to see this, absorption, distribution, metabolism, excretion, like, we've been there, done that, why do you tell us this again? Because the food that we eat or the drinks that we have can affect any of these phases of pharmacokinetics. And the interactions can also be at pharmacodynamic level. But the main thing to have in mind is that we are focusing mainly on the interactions that are clinically significant. If it doesn't change the outcome, if it doesn't change the effectiveness of the medication, if it doesn't make the medication toxic, then we are not interested in that interaction. It needs to be clinical significant. And where do we see more clinical significance is in our in the interactions of the drugs with a narrow therapeutic index. That's where we need to be extra careful. Yeah? So you'll see that most of my examples will focus on those kind of drugs with narrow therapeutic index. Okay. So in terms of pharmacokinetics, there are lots of factors that influence the absorption of a drug. I will not go through all of them. Some of them, probably you already counseled the patients about them, like the pH. When you dispense itraconazole, you tell the patients take it on an empty stomach. Why? Because the acidic pH will favor the absorption, or iron supplements, those kind of things. So I will not go there, but I will start by looking at contact time. And something that we need to be mindful is the fact that the presence of food delays the transport of drugs in intestines. And why is that relevant? Because if we talk about drugs that are slightly basic, they need to go in the intestines to be absorbed. And that the delay of the transport means the delay in absorption of the drug. Fatty meals and solid foods slow down the rate at which the stomach contact enters the small intestines, so they, in general, we know that they will delay the absorption. An interesting fact about theophylline, which has a narrow therapeutic index, is that despite the fact that it's not considered a highly lipophilic drug, the fatty meals increase bioavailability of this drug. So we need to pay attention to our patients with COPD, because that's where we see the medication mainly prescribed, or severe asthma, to tell them to avoid fatty meals. Yeah? They take it with food because of the gastric irritation, but not to be fatty. The meals shouldn't be fatty. Okay, and then we have our lipophilic medicines that require fatty meals. We tell the patients by default, make sure you eat fatty meals with this type of medication. When we talk about malaria, artemether lumefantrine, or antiretrovirals or antifungals. Okay. Then another interesting fact when it comes to the contact time is that the fiber-rich foods either tend to delay or they reduce absorption. If it delays, it's not such a huge problem. But if it reduces the absorption, then you have a problem because it will decrease the efficacy of the medication. So I put here some examples of fiber-rich foods. And then I carried on by pointing out some of the drugs that will have a decreased absorption in the presence of these fiber-rich foods. Antidepressants, like amitriptyline. And we shouldn't forget that amitriptyline is not only used for the antidepressant role, but also for the neuropathic pain. Digoxin. And then you wonder why your patient, and if you ask a dietitian, because this is why I brought my dietitian friend, because I bounce everything by her when I teach the dietetic students. I go to her, is this relevant in practice or not? If it's not relevant, I will not talk about it. If you think of your patient on digoxin, the dietitian will tell the patient you need fiber-rich food, you need healthy, balanced diet. And then digoxin will not be properly absorbed. You see the cardiac failure worsening, and you don't know why. It's because of the food that the patient is eating close to the use of digoxin. Then thyroid hormones, levothyroxine, yes, I know. Patients should take Euthyrox on an empty stomach before they do anything else, 1 hour before they go and eat and all of that. But you will see in a couple of slides that actually there are some factors that will influence the absorption even if it's taken on an empty stomach. Okay. Then if we look at our statins, yeah, that's another thing, very commonly prescribed. Most of our patients that are on statins, the dietitian will tell them, fiber-rich food, you want to decrease cholesterol, yeah? How do we change the diet? Okay, then expression of P-glycoprotein. Okay, probably this might not ring a bell at all. It's far, far in the past. If I didn't need to teach the dietetics, I don't think I would have gone to the P-glycoprotein anywhere close. But if we think about it, green tea. Some of us don't drink coffee. They drink green tea. And they drink green tea a couple of cups per day. That green tea will increase the expression of the P-glycoprotein, which decreases the serum concentration of few of the drugs. Again, something very innocent when you think about it can become problematic if it's used on a daily basis more than once. It's not about the random green tea that you have every now and then. It's about that constant intake. Okay, and on the other hand, grapefruit has the opposite effect. By inhibiting P-glycoprotein, increases the serum concentration of some of the substrates. Then we have another way of influencing the absorption of the drugs with the chelation of the drugs with food components. And I'm pretty sure you all remember dairy products and tetracyclines. I think that was drilled in our heads. Doesn't matter which university you went, where you studied, tetracyclines and dairies. And fluoroquinolones. Now, what I didn't know is that actually even the little amount of milk that you put in the coffee or in the tea will influence the absorption. So it will chelate with your tetracycline or your fluoroquinolone. Then the other example that I found quite interesting. If a patient is on a biphosphonate, yeah, again, we tell them, you take it in the morning before you do anything else, and make sure that you stand up, sit upright, yeah, because you want to avoid the gastroesophageal reflux disease. Okay. But what we don't tell them is that even if they take it with mineral water, that will decrease dramatically the bioavailability. And most of the patients, if you ask them, they will tell them, I don't like water. I want tea. I will drink it with tea. What's so bad about it? Guess what? Juices, coffee, supplements will influence the absorption of biphosphonates. Luckily, we have various formulations, and risedronate, the late release, is now able to bypass that malabsorption. So even if the patient will have it with mineral water, the absorption will not be affected. Okay. Then another mechanism to influence the absorption of drugs is the competition or the inhibition of OATP. Again, something that I found out, grapefruit, orange, apple, kiwi, papaya. Things that we normally consume. We want to be healthy. They are on our diet. 1-2 fruits of standard size or 200 milliliters of commercial or homemade juice inhibits the OATP. In other words, it doesn't allow for the medication to be absorbed. Which medication is affected? Fexofenadine. You are trying to treat your allergic rhinitis, and you take it with some orange juice or apple juice. Guess what? It will not absorb. And you wonder why you still have the symptoms. Because you, in an innocent way, you've done the wrong thing. Atenolol. From all the beta blockers, apparently atenolol is the only one affected. Ciprofloxacin, yeah. And guess what? Levothyroxine. Even within 3-4 hours, if you drink or eat these fruits, it will affect the absorption of levothyroxine. So these are small things that we never take into account, but they are relevant. Think of your patient with hypothyroidism, and they think, but I'm not feeling any better. I increased the dose. The doctor told me to tell me to increase the dose. I increased the dose, but still nothing. I still have the symptoms. Okay, Then lastly, in terms of the competition for the transporters is the catechins in the green tea. Here, nevertheless, the studies that I found were done on a very limited number of participants. So I cannot say that that's a limitation, yeah, with the effect on the treatment with rosuvastatin, erythromycin, and so forth. And then lastly, one of the oldest competitions for the transporter that we know of, and I know that my colleague that lectures this section for Parkinson always reinforces to the students, is levodopa and protein-rich foods. So our patients on treatment with levodopa, we need to always counsel them the protein intake should be spread throughout the day and small quantities, never high quantities because of the competition. Nevertheless, I found a study, actually it was a meta-analysis, that indicated that since levodopa is now combined with carbidopa, the influence of proteins in the food is not as high. So the patients can have a bit more proteins in the diet and bigger quantities that will not affect the absorption when combined with carbidopa. Okay, this is one of my favorite when it comes to absorption. Have you ever heard of goitrogenic foods? But you do eat broccoli, huh? And you do eat cabbage. Guess what? It's a goitrogenic food, people. What does that mean in pure English? Means that the substances that we find in these foods inhibit the uptake of iodine by the thyroid gland. So your hypothyroidic patients, is that even English? Okay, patients with hypothyroidism, let's put it like that. If they have a high, because the thyroid needs iodine to produce T3 and T4, yeah? But if you, and my dietitian was also telling me, but we tell the patients to eat iodine fortified foods, yeah? And all the salt has extra. But if your patient is hypertensive and has hypothyroidism, the dietitian will tell them, don't add extra salt. So there is a problem there. We need to be mindful of these things. Okay, so that is what the drug absorption side. And now let's look at metabolism. Now this is the part that all the students hate. When we talk about cytochrome P450, ooh, it's like the end. Okay, so just a reminder, the liver metabolizes drugs into phases, and our main focus now will be on phase 1, where the cytochrome P140 is involved. There are a huge number of enzymes involved in the metabolism of drugs, and the same enzymes are involved in the metabolism of food. Main one, cytochrome P3A4, because it's responsible of the metabolism of more than 50% of the drugs that we take. And then we have others. Don't worry, I'll not go through all of them. It's late. I would like for you guys to still like me. But I will focus on cytochrome P182 and 3A4. Okay, so let's start with P182. While the food influences the absorption of a drug that is metabolized by any of cytochrome P400 enzymes, it's not only food that influences the metabolism, it's also our genetic makeup. If genetically, and this is where my passion for pharmacogenetics comes in, because you do a pharmacogenetic test and you see if you are a slow metabolizer or rapid metabolizer, and then you understand why the medication is not working or why do you have side effects, how you need to change the dose to personalize the treatment for the patient and save the time and the money and not have trial and error with the patient from a drug to another. Okay, so as a general rule, apparently, the activity of the cytochrome P450 is inhibited by wines, beers, but also in the case, we see the inhibition of the enzyme in the case of patients that are on keto diet. When their diet is very high in protein and lipids, and the good lipids, again, but poor in carbohydrates. So you think that you are eating healthy, you have a high intake of protein, the very good lipids that I put here, some examples, but poor in carbohydrates, but that will inhibit the activity of the cytochrome P40, which means that any medication will be metabolized at a slower rate, it will accumulate, and it will cause side effects. Okay, so the outcome is detrimental for the patient with increased risk of side effects. So I didn't mention at the beginning, but please feel free to ask questions. You don't need to wait till the end. So while I'm talking, you put your hand up and I can try and answer. So if we look at the cytochrome P182, and I just put here some examples of the drugs that are metabolized, not to say that these are all, that are metabolized by this enzyme. The enzyme is induced by cruciferous vegetables. Yeah? Cruciferous now, I think all of us remember your broccoli and your cauliflower and your cabbage, but is inhibited by apiaceous vegetables. Now, when I saw this, like, what's that? Because I don't remember in botany what apiaceous vegetables are. Guess what? Do you use carrots when you cook? Parsley. Parsley. Celery. Those are apiaceous vegetables. And apparently, the inhibitory effect lasts for 24 hours on the cytochrome P12. And when patients were given, healthy subjects were given cruciferous with apiaceous, so some cabbage and some carrots, the inhibitory effect of carrots was stronger than the inducing effect of the cabbage. So now you need to think, if I'm on theophylline and I cook and eat on a daily basis with this type of vegetables, what will the effect be on the metabolism of these drugs? And then we have other inducers, one of the most important ones being smoking. Smoking, it's an inducer of the cytochrome P12. Now, how many of us actually counsel the patients on theophylline on the effect on smoking? Because if you stop smoking suddenly, then if you do a therapeutic drug monitoring, you will see theophylline levels going up immediately because you don't have the inducing effect of smoking. So that is something that we need to be mindful of. Inhibitory effect, grapefruit juice, conflicting data, so we'll not waste our time on that. Now, another thing with the cytochrome P12, and the reason that I chose it, how many of you are drinking coffee? And if not coffee, teas that have caffeine, or drinks like your Powerade or things like that that have caffeine. So heavy consumption of caffeine increases the activity of the cytochrome P12. So it becomes and has an inducing effect, meaning that the drugs that you take that are metabolized by this enzyme will end up being less effective while you are busy drinking your caffeine. What I found extremely interesting is interaction of caffeine with clozapine. So a few studies show this interaction where the caffeine raised the concentration of clozapine in the bloodstream by 20 to 26%, which is not an inducing effect. It's actually competition for the enzyme. Who gets to be metabolized first? And caffeine won that competition, meaning clozapine stayed in the bloodstream. And the patient started to experience side effects, severe side effects. When your serum concentration increased by 26%, then you will have those side effects. And on the other side, we also need to think, what about the effects of the drug inducers and the drug inhibitors on caffeine? If you are starting treatment with a drug inhibitor, yeah, and you are drinking caffeine, what will happen? You will end up building caffeine, and you will start to shake and have all the side effects and insomnia from the caffeine. Okay, so that's cytochrome P182. Now let's look at the big brother, cytochrome P384. Again, lots of drugs metabolized by this enzyme. I just want to point out grapefruit juice because we know it as a potent inhibitor of the cytochrome P384, and the inhibition lasts around 48 hours. So grapefruit and grapefruit juice, and all the studies indicate that the inhibitory effect of fruits and fruit juice, the fruit juice, it's stronger when the juice is homemade than the commercial juice. Okay, our alcohol acute use has an inhibitory effect on the cytochrome P384, whereas the chronic use has an inducing effect, same as garlic. So if you like cooking with garlic, almost every dish has some garlic, then you need to think that that has an inducing effect. Okay, let's move away from the metabolism and let's focus on the last phase, on excretion of the drugs, just to close with the pharmacokinetic side. Aloe juice increases the risk of hypokalemia in patients with thiazide diuretics, glucocorticosteroids, and digoxin. And we know that if we have hypokalemia in a patient with digoxin, then you will experience all the side effects of digoxin and toxicity. The mechanism, apparently, the mechanism behind it is because of the laxative effect that causes loss of minerals and nutrients. Okay. Lastly, when the excretion is lithium, and I haven't spoken about lithium so far because lithium is one of those drugs that is not actually metabolized by the liver. It's excreted unchanged. But when excretion time comes, lithium excretion is highly influenced by the sodium intake, and we know sodium intake is not only from how much we add in our food, it's what we are eating. Have you ever looked on your breakfast cereals, how much sodium you have? It's scary. It's scary. All the savory snacks. That nice biltong, nice but not so good if you're on lithium. Then urine alkalizing foods, and I put here some examples. They decrease the lithium reabsorption. So what's the outcome of that? Lower serum levels of lithium, with the patient starting back to have the mood swings. So your patient that was previously stabilized with their mood swings, now they start to experience again the symptoms. So if high sodium intake leads to return of the mood swings, then hyponatremia, that can be caused by various things, starting with telling the patient you are hypertensive, you shouldn't add extra salt to your food, or you go for a run and you perspire a lot, or you have diarrhea, increases the reabsorption of lithium, leading to toxicity. And again, we know that lithium is one of the drugs with neurotherapeutic index, so that is very likely to happen. So message for patients on lithium is not to have a high variation in the sodium intake. They need to be consistent there. And guess what? Caffeine, again, influences the excretion of lithium. So there was a study that was conducted on patients on lithium that drank quite a bit of coffee, because let's be honest, 6 coffee, like how many cups per day do you drink? 2? I see there like a guilty face. 3, 4, okay. So I think this is a bit of exception, but nevertheless, you have those odd patients that end up with 4 to 6 cups per day. And now, the moment they took the coffee away from these patients, the lithium levels in the bloodstream went up. Why? Because there wasn't caffeine there to help with the excretion. The moment they brought back into their diet caffeine, the lithium levels went down without changing the lithium dose on a daily basis. So we need to make sure that if the patients on lithium want to stop caffeine intake, then that needs to be done gradually. Okay. So we are done with pharmacokinetics. Everybody still with me? No? Do you want to go have a walk, come back? Have I bored you to death? Okay. Pharmacodynamics. So now we are looking at mechanism of action. Yeah? Promise, this is the last time I tell you about caffeine. Hopefully this will keep you awake if I tell you about it, if you don't drink it. So caffeine impairs the methotrexate efficacy. And we know that methotrexate doesn't have only one indication, multiple indications, so the profile of the patient can be different. And then licorice. Licorice mimics the effect of mineralocorticosteroids. So what will it do? It will increase the reabsorption of salt and water on one hand, and will push away the potassium. So patients will end up hypokalemic, not only from licorice, but if you are already on medication that causes hypokalemia, when you crave something sweet and you go for licorice, then be prepared that if that's happening on a daily basis, that's your go-to sweet, then that will worsen the hypokalemia. Otherwise, it will affect the mechanism of antiarrhythmics, antihypertensives, and digoxin. Now, one of my favorites, cinnamons. What I learned, and I didn't know before, is that actually patients go and buy cinnamon capsules. I didn't know that. Obviously, I knew that cinnamon has antioxidant properties. I knew that has neuroprotective activity. What I didn't know is that it actually lowers the plasma glucose level. So patients that are diabetic on treatment with some of the sulfonylureas, I'm not sure if glipizide is still on the market. Is it still on the market?
Yes, it is.
Is it? Yes. Okay, but was it out of the market for a while or out of stock? Thank you. So, okay, perfect. Thank you. No, I'm joking. No. I know. Like, just get it done and over. I know. So, cinnamon has synergistic effect with anti-diabetic drugs, which means that we need to pay attention to hypoglycemia. So the interaction will not come from the cinnamon that you put in your coffee to make it smell better and taste better in the morning, but it will come from those capsules that the patient is taking. Okay. Then tryptophan. Yes?
The benzamide is off the market, not glipizide.
Okay, perfect. Glibenclamide out.
Glycamine is out on ons. Sorry. I'm retail, I don't know.
Okay. Okay. So tryptophan, precursor of serotonin and melatonin. Yeah? So we need it in the diet. And we need it in the diet, especially if we are on antidepressants and SSRIs. So your patients that are on SSRIs shouldn't have a tryptophan-free diet. Now, we tell this to our dietetic students. Please, if you have a patient on SSRI, don't remove the foods rich in tryptophan from their diet. But shouldn't the pharmacists know that as well? That tryptophan is important there for the SSRIs to actually use that serotonin efficiently. Okay. And then, oh, wait. Oopsie. Okay, wasn't exactly what I was planning. Okay, so if I tell you linezolid, what condition are you thinking of? Linezolid? TB, yeah? TB. Fair enough, TB. If I tell you isoniazid, what do you think? TB, yeah? So we are all on the same page. Imagine my surprise when I found out that linezolide actually was firstly a psychotropic agent and has monoamine oxidase inhibitor properties. So that was quite interesting. And it has been associated with serotonin toxicity and serotonin syndrome, especially when given to patients on SSRIs, SNRIs, and isoniazid. A patient with TB most probably, because it's on linezolide, which is multiple drug-resistant treatment, yeah, most probably might be depressed. So your patient might be on one of these antidepressants. Now you add linezolide, and you have a risk of serotonin syndrome. Okay, that's drug-drug interaction. Sorry, let's go back to drug-food interaction. So it will increase the effects of tyramine by pharmacodynamic synergies, and we'll have a risk of acute hypertensive episodes in patients that consume tyramine-rich foods. So we need to make sure that we tell the patients on linezolide to have a lower intake, not to take them all out of the diet, by a lower intake of tyramine-rich foods. And if you are interested, I can email you the lists that are official from various bodies, international bodies, with lists of tyramine-rich foods and so on. Isoniazid, on the other hand, guess what? Mild non-selective inhibitor. It was actually first used as an antidepressant. And besides being an inhibitor of monoamine oxidase, it's also an inhibitor of diamine oxidase. Diamine oxidase is the enzyme that actually metabolizes the histamine from the food. Have you ever wondered why skin rash is one of the side effects of isoniazid? Because we all know it is. We all know that the patients end up back complaining of skin rash, and you don't know if it's coming from isoniazid, rifampicin, or which one of them. But because of this inhibition of diamine oxidase, we have a problem with isoniazid and the skin rash. And we want to tell the patients, in order to avoid that, to actually decrease the intake of foods that are rich in histamine. Yeah? Because you don't have the enzyme available to break it down. So you will have high levels of histamine, which will cause the skin rash. It's not an allergic reaction to the medication, it's the release, the high level of histamine that causes the problem. And because of the mild inhibition of monoamine oxidase, it also tends to increase blood pressure slightly, especially if we are talking about foods with tyramine in them. And as a general rule, foods that come in a can, I wouldn't call them exactly foods, things that come in a can, ready meals, ripe and fermented foods have a higher histamine content. Could you believe it that eggplant, the innocent eggplant, has one of the highest levels of histamine? Like something innocent. And I was fascinated when I was reading the list of foods rich in histamine, and then you have foods that actually also inhibit diamine oxidase. So you have foods that inhibit diamine oxidase, you have isoniazid that inhibits that diamine oxidase, then you'll see the skin rash in the patients. Okay. Lastly, on the pharmacodynamic side, warfarin. Yeah, warfarin, and I believe that most of the hospital pharmacies do hand in a leaflet with the foods that should be avoided by patients. This is why I haven't spent a lot of time here. Yeah? We have foods that are rich in vitamin K, but the main message for patients on warfarin is to avoid the fluctuation in vitamin K intake. Any intake more than 150 micrograms per day will affect the way warfarin works. So that is more or less, again, is it in our scope to tell them how much of that? No, this is why we need to refer them to dietitians to get their meal plan in place. And this is why I think tonight would have been great if we could have had few of the dietitians around to actually start working together and know when it's time, because if the interaction is not relevant clinically, we don't bother. But otherwise, to tell them, listen, somebody can draw a meal plan for you. It's not me. but that's a different story. Okay. So a quick look at the dietary adjustments required with medicine use. Here we are just quickly looking at the medication that normally influences the patient nutritional status. And we never think of these things. Like, how often do we tell the patients on antipsychotics, like risperidone, clozapine, that they need to actually go and see a dietitian because they will start to gain weight, their appetite will change, they will end up with high cholesterol, glucose levels will go up. Do we tell them? Not often enough. And then what do? They stop being adherent to the treatment because they experience the side effects. They don't like the side effects. And can we afford that with patients on antipsychotics? We cannot actually afford that. And then we have various drugs that alter the appetite. Taste distortion, it's another problem. Do we point it out? Often enough to the patients. Because the moment your taste changes, you might not want to eat. And this comes with chronic medication, your ACE inhibitors, your carbamazepine. Those are chronic. It's not something that the patient will just get over it in 5 days' time when the course is done. Then the taste disturbance, and I put it here in italic, metformin, allopurinol, metronidazole. I don't know if you ever experience a taste disturbance from a medication. That metallic taste that you have from metformin, allopurinol is disgusting. It's almost you have a knife in your mouth all the time. The food doesn't taste nice. Now imagine that that's you all the time. Will you want to eat? Or will you push the food away? And then when it comes to impaired of gastrointestinal function, do we actually tell the patients on anticholinergics, on tricyclic antidepressants that they need to change their diet because they will end up with chronic constipation? Do we reinforce enough on that? That's just some food for thought, seeing that we're eating and eating. Okay, and then lastly on the dietary adjustments, just a few reminders with isoniazide, always increase the vitamin B6 intake. With valproic acid and carbamazepine, we need to increase the vitamin D metabolism with the risk of osteoporosis. Very important with PPIs. PPIs, not only that they are decreasing the absorption of vitamin B12, but also calcium. There are a few studies that looked in omeprazole, and they show that in patients that already have osteoporosis, and they are on omeprazole for more than 6 months, the calcium levels, when they done the bone scan, the calcium levels decrease tremendously. And we need to be mindful of that. Okay. Actually, no, there is one more thing that I want to tell you about the dietary adjustments and medicine use, is the keto diet. I never knew that ketogenic diet was actually developed to help patients with epilepsy. So the first time somebody thought of this type of diet was to help patients with refractory epilepsy. Why? Because the ketone bodies have anti-seizure effect. And this is how ketogenic diet was more and more used. Problem, though, is that the levels of anticonvulsant medication is significantly decreased when you're on a ketogenic diet. So obviously, your epileptic patient cannot be controlled only from ketogenic diet. They need their antiepileptics. And then that influences the level of serum of the medication. And a study conducted on adults with focal and generalized drug-resistant epilepsy showed that a modified Atkins diet decreases significantly the clobazam levels. Okay, and that's it with the dietary adjustments. That's a bit different from ketogenic diet, but I thought just to raise awareness that soy products decrease the valproic acid levels. Again, patient will not be controlled. And quick look through supplements and drug interactions. One of the challenges when it comes to herbal supplements is the fact that we don't have studies, we don't know their composition. Some of them can be contaminated with heavy metals. And there were some studies that show that some of the herbal compounds can activate the nuclear receptors. And from there, lots of interactions. I chose 2 herbal supplements to talk about. St. John's wort, an antidepressant. Patients can just go and grab it. They don't need counseling, unfortunately, but increases the serotonin level. And not only that increases the serotonin level, but is an inducer of the cytochrome 3A4 for weeks after the last dose, making the medication that is metabolized by the cytochrome 3A4 ineffective. Okay, so what drugs can be affected by St. John's wort? Immunosuppressants, cardiovascular anticoagulants, or statins. And back to respiratory effects of phenidine, even some of the antiretrovirals. Okay, and then lastly on the herbal, ginkgo biloba. Ginkgo biloba, brilliant, reduces platelet aggregation, but if we think of the fact that it inhibits cytochrome 2C9 and 3A4, then it will affect the warfarin metabolism and should be avoided on all the patients on antiplatelets or anticoagulant drugs. It's not something that we want for them to use. Even more, ginkgo biloba has agonistic action with GABA system, which means that you'll have an interaction with benzodiazepines and has a serotoninergic effect, interactions or SSRIs. Something innocent that patients think, okay, I need ginkgo biloba, it will make me think clear, it will increase the blood flow to my brain, you know, help me stay focused. And fish oil. Fish oil decreases the blood coagulability. Again, very good if you are at risk of coronary heart disease. But if you are already on anticoagulants, you are at increased risk of bleeding with fish oil. Okay, other supplements, iron supplements, I think you guys know them. They are quite often used, so I will not insist on that. I just want to bring this to an end with saying that a drug-nutrient interaction, yes, is clinically significant only if it alters the therapeutic response. And the focus will be only on the drugs with narrow therapeutic index, medication that normally we do therapeutic drug monitoring. And in general, be mindful of tyramine-rich foods, tryptophan-rich foods, goitrogenic foods, citrus fruits, and caffeine and smoking. So those are the main things that I hope you will take with after tonight. That's me. Thank you very much. Okay. Any questions? Yeah, no. Everything needs to be balanced.
Stopping on medication.
Or rather prevent and not get sick, and then it's even better. Thank you very much.
Thank you very much for your time and for effort and putting forward such a great presentation. And that's a little
Thank you very much.
gift for you. And I would like to point out to everybody that first of all, I'm sorry that we have to keep on changing the venue, but it depends on which venue is available at the time. It's been pointed out to me that maybe 6:30 is a little bit early. So maybe next time, maybe next month, we'll make it the starting time 7 o'clock, which might suit a few more people. The advantage of attending a CPD is not only to listen to an interesting presentation, but it's also to meet your colleagues and have a nice conversation with them. So please don't rush off after this evening. Please have another drink. There's food available still. And you might also recall that we were going to have a lucky draw this evening, and in fact that is going to take place. So let me just get the things out of my briefcase. I put in a packet all the people who agreed to come tonight, and their names are all in this envelope. So I'm going to ask one of these gentlemen in the front to just take one name out of this envelope, just one name.
I should have put my hand in.
It's difficult, I know. Are you going to say who it is?
Oh, I thought that you will be the next presenter. Yeah. Thank you very much.